Hello, everybody, and welcome to the University of Queensland's Faculty of Health and Behavioural Sciences Alumni Webinar Series. My name is Paul Purcell, and today we'll be joined by Professor Ove A from the UQ School of Dentistry. Today, Professor Peters will explore endodontics and root canal treatments following considerable worldwide discussion on the topic following a recent feature film. I begin today by acknowledging the traditional owners and their custodianship of the various different lands on which we all meet. On behalf of the university, I pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. For those of you joining us live today, you're encouraged to ask questions via the Q&A function, which you can find at the bottom of the screen. We'll endeavour to have a little Q&A session at the end of the presentation, so please feel free to put those through as the webinar goes on, and we'll get to them then. Additionally, this webinar is being recorded. So for those of you who have registered, you'll receive a link to the video early next week, or you can forward on the link, which will be on the HaBS Alumni Webinar page. And now, it gives me great pleasure to introduce Professor Ove A.
Thank you very much, Paul. This is an absolute pleasure to be with you and the audience today. And in fact, just 20 minutes may not be enough to share some of my thoughts with you, but let's take it from here. My title is Root Cause or Essential Benefit. What is endodontics really? I'm certainly aware that not everybody that's listening in is a dentist. And that's fine because we are involved in many things in different roles as either a patient.
Sorry, Ove, I'm just going to have to cut in. You've accidentally muted yourself there. So you were going for, and something just happened in the middle there. Sorry.
How did I do that?
I'm not sure, but there you go. You're back now. So sorry, I didn't mean to interrupt.
Okay, no worries. That's it. This new world of videos and Zoom conference and so forth, and that does happen. Well, I was just going to start and talk a little bit about why I'm going to be interested, and maybe hopefully I can interest you in this topic. And in fact, that has to do with my background. And I've looked at multiple scenarios in terms of healthcare systems and also in terms of what the professional role of a dentist is. I'm originally German, as you may very well hear. And I worked in private practice in oral surgery and also in a prosthodontic university clinic in Germany for many years. But prior to that, I was a full-time research associate at the University in Kiel in Northern Germany in the Institute of Physiology. I was then at Zurich Dental School for 7 years, a total of 18 years in San Francisco, in an endodontic role for the last number of years as the chair of a fairly large endodontic department at the University of the Pacific. In the meantime, I also was doing oral surgery as a volunteer dentist on the island of Jamaica. And as you can appreciate, how much difference is there in healthcare, in socioeconomics, comparing Zurich and Jamaica, Port Antonio to be specific? Well, people are still people in need. And so let's come back to the original starting point, a root canal treatment. When you think of a root canal treatment, as a dentist, you think of a beautiful white line in the curved canal. You think of a artfully done, clinically workable root canal treatment. But a patient looks at it differently. Patients dread a root canal treatment. And I'm pretty sure all of you who have gone through this scenarios yourselves can agree with me. What does it really mean? Well, that means that the groundswell, the starting point for what we are providing for dentistry is not necessarily a good one. However, the net result for those who have successful root canal treatments is by and large excellent. Now, this is the starting point, as I mentioned, but then this happened. I was here at UQ on a sabbatical 3 years ago. And during that time, I was called up by many of my friends in the US because they had seen this. This is a snip, just a little intro into a full feature-length movie. And I've cut the sound, so you're not hearing anything, just me. So what this is an individual, as you can see, healthy young man, and he has a problem. And there's a couple of authorities that talk about the problem and so forth. Do you recognize this? I recognized it. This is Surfer's Paradise, of course. And I think the sand dunes were on Strati. It does hit a nerve for the audience that this is tailored towards. So a lot of people are there that accuse a root canal treated tooth to be the cause of all ills. And it could be, this is in Brisbane, as you can tell. And so I had to tell my friends in the US, oh, this is not the groundswell in Australia. This is not the strategy. And this individual is now in dire straits and nothing is okay. His health is compromised only because he has this root canal treated tooth stemming from the physical altercation where this other individual knocked out his tooth. All kinds of alternative treatments did not help. Let's stop this movie here. I think what does happen is, and this is a lady that is explaining why breast cancer is associated with root canal treatments. And when you look at what healthcare is, really, it's more than just looking at a technical aspect, obviously. Healthcare has to do with, for lack of a better word, with a holistic approach. So we as dentists have not really paid due respect to that type of approach for certainly not in academia for many years, but that has changed relatively recently, both for periodontology and also for endodontics, because it has become apparent that there are parallel interactions between certain oral cavity scenarios, inflammation, and also overall health of the patient. Well, it's not surprising, really, because the oral cavity is not completely separate from the rest of the patient. How could it be? At the same time, it is not quite as simple as this movie, The Root Cause, would have made us believe. So we published this paper a couple of years ago with collaborators in France and in the US, where we tried to figure out how objectively can we actually ascertain that there are any kind of relationships and between the oral cavity and the ongoing infection and inflammation and overall health. The example that we selected here were patients that had certain imaging and other diagnostic tests done prior to major surgery, let's say organ transplant, cancer treatment, and stuff like that. And particularly, this is important because more often than not, these patients have immune compromising scenarios. And the belief is that the oral cavity with all these focal infections and what have you is a problem. As when I say belief, there is no focal infection. This scenario has been completely debunked and was a major problem in clinical endodontics in the early years of the 20th century, where wholesale extractions were proposed and actually done in order to remove all the negative effects from root canal treated teeth. So that as a starting point, hopefully gets you interested a little bit in the rest of what I'm going to say and talk about today. This is the realm of conventional endodontics. Conventional endodontics is not good or bad, it's the technology and it's the strategy that we use at the moment. What is it really in its best kind of scenario? The goal of root canal treatment is to prevent, or if there's already present, treat apical periodontitis, periapical periodicular inflammation. That is the idea that we work under for conventional endodontics. And this has been very well supported in literature, and is when I'm talking to my postgrad students, certainly what they should answer. Treatment standards, and we wrote this treatment standards paper for the American Association of Endodontics, are derived from that kind of approach. Treatment standards would look at how can we best remove infection? How can we best get our inflammation level to zero if possible? And this is the presentation for a patient clinically, radiographically, and the histologic correlate to that. Obviously, not every tooth has frank caries as the anterior that we are looking at in this radiograph, and it's in the clinical image, but other scenarios are also associated with root canal problems such as trauma. Again, conventional endodontics, there's a logic to that, and this is the underpinning of what many of us do, most of us do in our practices from on a daily basis. That's not the only way of looking at it, as we will see, but we need to be as good as we can in conventional endodontics. And I have done quite a number of things, and I will only highlight two over the last 20 years where I've dealt with the conventional endodontics. One is how to prepare, how to shape a canal. And we use a very elegant technology called microcomputed tomography. And we are looking at a tooth here on the lower left of the slide that is micro CT scanned, and you can in vitro at this moment, and this is done 20 years ago, you can take this tooth out in a computer and can actually go to the inside. We're in the pulp chamber now, and we're kind of flying out of the palatal canal, which is very cool, but that's not what we wanted to do. What we wanted to do is seen in the rest of the slide. We measure in 3 dimensions independently from any kind of additional problems or additional obstacles, exactly what the root canal anatomy is. The movie is moved ahead, and now we're seeing the root canal anatomy of a maxillary molar. The image on the right is a mandibular molar, and we're looking at increasing canal size shown by these colored images, and also the 3-dimensional shape, the curves, the movement after canal preparation towards the more critical so-called danger zone. That's the gold standard, and we can say that we established this gold standard in terms of instrumentation research. Another element is this kind of scenario here, and this is a recent paper, 2020, where we use certain technologies to test the mechanical properties of root canal instrumentation. Of course, the instrument should perform. In order to do this, we are not using hand instruments, but mechanical instruments seen in the top right on the slide. These are worked not by a machine as I'm using here in vitro, but electric hand pieces. And the way this works is decisive for the technical success of conventional root canal treatment again. We'll work on this, and this enables us to develop new instruments, to develop handling properties, a handling structure, and to enable, and in the end of the day, clinicians to be successful with root canal instrumentation. That is a very important thing, and traditional endodontics clearly is going to be conventional, is going to be with us for some way in the future for sure. Now, there is another thought process. It's not only about removing inflammation, it's about the long-term perspective of the tooth. In other words, is this tooth free of pain? Is it still in the mouth? Is it functional? Is that supportive of the oral health of the patient? This is a paper out of Gothenburg, Sweden, a very strong research group. Landesbergen is the first author, but Thomas Christ is the lead person here. And in Sweden, they have a scenario that is certainly not thinkable in the US, and not quite as thinkable in Australia. Every single tooth that is root canal treated, irrespective who the provider is, goes into a database. So they can go look back after 10 years, what happened to all of these teeth. And they just took a random sample, 420 teeth, and they found that after 10 years, the overall outcome is still relatively good. I would say not 100%, so it's not perfect, not even 90%, but these teeth, about 82% of a random representative sample was still in the mouth and functional. What's more important is that out of the extracted teeth, out of the teeth that are lost in the observation period, only a handful, 5 to be exact, were lost due to endodontic problems. The other teeth were lost due to restorative problems. And this comes back to the question of holistic, for lack of a better term, approach. The restoration, the usage of the tooth, the way the tooth is utilized is in many countries, certainly in the US, removed when a tooth is being treated by an endodontic specialist, removed from what is the original starting point. I neglected to complete the analysis here, and this group, Landesbergen, looked at some specific statistic questions. What is a relevant? Restoration placement is a relevant factor. What is the patient gender is a relevant factor, and also how old is the patient. All of these things can be explained. Time is not enough, not sufficient today. But the point that I'm making here is it's not only resolution of inflammation, it's also what is the long-term perspective of the tooth that we're dealing with. And this is what I mean when I talk about the career of a tooth, right? When we have our first molars erupt in all their structural integrity at maybe age 7 or so, we are set up for a long period, but it's a downhill journey. And regardless if you are a patient or a parent or a provider, you are aware of this, because as soon as we start repairing the tooth, a restoration, a filling, a crown, what have you, the structural integrity of the tooth is reduced. And then the endodontists go to work. And it's really a downhill journey that culminates in this. That's the extraction forceps. I do know that one of my colleagues, Dr. Gulati, had a presentation on implants. An implant is a perfect solution if nothing else will work. And this is at the end of the service life of a tooth, or when a tooth is not present to begin with, or lost for other reasons. But my strategy would be slightly different. We want to stretch the curve and don't come to the extraction time point, and this is made up, of course, at age 60, but considering that our patients, and we all, live longer than ever before, we want to be mindful that every step along this curve is caused by an action. It's caused by a dentist who thinks the restoration has to be removed. It's caused by a patient who doesn't want the aesthetics anymore. So there's a cause and effect for these things. So the career of a tooth needs to be kept in mind. It is different if the patient is 20 years old and receives a root canal treatment, or is the patient 55 years old and receives a root canal treatment or a crown. So this is a very interesting paper, and I invite all of you to read up on it, and I'm happy to interact with you. John Ioannidis is a statistician at Stanford in the US, and his take is criticism, right? When is it time to abandon ship? When is it time to reverse established practices? I don't have, again, not enough time to go into details, but he has a couple of very interesting points to make. And if you're in the medical field at all, look up John Ioannidis. So for me, the consequence of that thought process was what I would like to term transformational endodontics, with the beginning of an approach that looks at the overarching goal. The overarching goal of what we're doing here is to aid in the long-term retention of teeth, because that supports oral health and overall well-being of patients. Not because we want this, because it's good for our patients. So this includes the timely placement of a restoration, meaning as soon as possible. These are a couple of events that I was participating in. This is not a new idea, and I've been talking about this for at least 10 years now, 5 years very specifically, with this joint symposium that we had in the US. But overall, that is not 100% accepted, and the specifics of this approach are not clear to everybody. This is an example of a former student, from resident of mine, Dr. Salman, who practices in Denver, Colorado. And he's doing a root canal treatment to a patient that is a younger patient, maybe 20 years old, 22 years old. An upper second molar has deep caries, is in need for a root canal treatment. And oftentimes a crown would be placed for a patient like this. What we're doing differently now is we are very cognizant and very diligent in removing as little as possible as far as coronal structure, and provide a root canal treatment that is as efficient as we could ever have dreamt of, but doesn't take away as much tooth structure. The core of root canal treatment is enlargement, preparation of the canals. And I'm not going to bore you with the clinical details, but when you take a look at the radiographs on the right side here, this is the unprepared tooth. This is when the trial in of the so-called gutta percha, these white lines, is the filling material, occurs, and this is the finished product. For a trained eye, it looks somewhat different than before. Many patients wouldn't notice the difference, but the net effect is that the structure, the coronal anchorage of any restoration is much better. That's not all, of course. This is still a transitional period between conventional, transitional endodontics and transformational endodontics. And if you're trying to do something new, it's always good to look back. This is a paper out of 1974. Louis Grossman, one of the founding fathers of endodontics worldwide, talked about exactly the same thing. He finds a word for that's preventive endodontics. Not doing the root canal treatment. The best root canal treatment is the one that didn't occur. That brings us back to the beginning, to the video, right? If we have the ability to retain viable tissue rather than remove tissue and repair it with something, if we can functionally reconstitute tissue, it's much better. That's not only in big medicine, when we are replacing organs, not with machine, but with a new organ, maybe based off stem cells, right? And that is another element of my research. And when you think of it systematically, anytime we can retain viable tissue, this is a less invasive, less complicated for the most part, and certainly less expensive treatment. We call this vital part therapy. And anytime we have the word vital in here, that means that the structure, the perfusion, the cells are active and can therefore fight off, or at least help fight off infections, fight off bacteria. As soon as we have a root canal treatment situation, either with what we call a necrotic, a dead pulp, or a nerve, or we have a retreatment, or we have apical surgery, then we have to deal with bacteria that have established themselves, and also fungus that have established themselves somewhere deep in the root canal system. That is inherently a problem. And when you look at this, this is cumulative success rate, global success rate. Of course, when you have a simpler method that may be okay, maybe not, but this is also a least invasive method. And the further you go to the right, the less and the fewer fallback options, additional possibilities do you have. That means the cost goes up and the requirements in terms of clinical skill set, in terms of technology, goes up as well. And the number of patients that can participate and can actually benefit from that treatment is much lower on the right. That cannot be the best strategy. We have to find a sweet spot on the left side somewhere here. Let me just tell you a little bit how I see the transformational endodontics going forward. So for instance, this is a paper that we published 2 years ago with some additional work done just this year with a group in France. Alexis Godin is the lead author on this paper. We're using stem cells that are located on the tip of the root. We see this on the image on the top right. We call these stem cells of the apical papilla. And we can manufacture certain tissue responses. And we can use this either to test as almost like a molecular laboratory, test the responses of biomaterials in the lab. We can also modify and stimulate local cells that respond similarly to the apical papilla stem cells that are actually shown in this light microscopic image on the right. This is another thing that we do. We're looking at molecular mediators, and particularly we are looking at pro-resolving mediators. These mediators are looked at also in some other arenas, for instance, in stroke treatment. And in fact, endodontic problems, more often than not, are very similar because it's a reperfusion injury. We could show in this paper, also published in 2018, for the first time that the lipoxin receptor is actually constitutively expressed in apical papilla cells. So that is a novel approach that can help the body work itself through challenges more effectively and repair itself, rather than for us as clinicians take out a drill or take out whatever tools we have to mechanistically, in a way, repair the problem. Lastly, diagnostics, and we are working with certain technologies, and this is just a generic X-ray technology, and we're looking at, for instance, molecular mediators in terms of diagnosis also. And we can do this in different locations. We are at the beginning of this process. We have done some clinical studies on it. This is from a review that we published in 2016, where we looked at individuals and individual papers and individual mediators. Probably it's a network, not just one particular elevated inflammatory marker that we have to look at. And again, this is more complex. And certainly this is where the journey is going to lead us. That's no doubt about it. It's not only us, not only my group that works on it, but quite a few others worldwide are behind this. Let's close this out by talking about the perspective that is a little bit more global than looking at one paper or another paper. We have a distribution problem. We have an enormously high number of patients. Just give you a ballpark. In the US alone, 20 million root canal treatments are done on average per year. Worldwide, we think about 50 million root canal treatments. So not every patient can afford going to a specialist, quite obviously. Not every dentist is equipped to be doing every root canal treatment. That by itself is already a problem. How to solve this? And this is not trivial, obviously. How to solve this? Nobody has a simple answer. A little bit more complex answer, number one at the moment, is the triple aim. The triple aim is something that Harvard University came up with as a requirement, as a stipulation, how healthcare should develop. And the idea is to improve the point of service care, what I'm doing to this particular person, at the same time be cognizant of population health and do the whole thing for less money. That is, we call this the proverbial square peg in the round hole. That is very difficult. Another concern is, how can we do this better? Precision healthcare is another question that has come up. How can we tailor an approach that is specific for the patient in front of us that could actually help reduce cost and certainly improve outcomes? These are thoughts that we have to keep in mind when we want to invest a whole lot of money, a whole lot of training, and also educate our patients. I think it's worthwhile looking at whatever treatment opportunity is there and look at their effects long-term and for the population, not just for the one person in the chair sitting in front of us. So in that sense, endodontics certainly is not the root cause. There's absolutely no evidence whatsoever to suggest that that's the case. Endodontics is one element, and endodontic treatment in the scope and the breadth of it is a very important adjunct to retaining teeth and by that token, support overall well-being and oral health of our patients. Let me close with this, I think, fairly important slide. And it's out of business, and it supports many of the thought processes that I have for me in my role at UQ, but also in principle as a human being. In order to accomplish something, the 3 Ps are required: people, process, and purpose. What do I mean by that? Obviously, nobody can do this by themselves. And all the things that I have mentioned were done in larger research groups. Process is equally as important. If we don't have the situation, the structure, the technology, we're not going to go anywhere. But purpose is probably the most important question. Purpose allows us to develop strategies, and these strategies should directly underpin and support the purpose. If the purpose of endodontic treatment is to aid in the long-term, lifelong retention of teeth, our strategies have to be commensurate with that. I'll leave you with this and this photograph that I took when we were at Uluru with my wife, speechless in the front left here. It has been a phenomenal journey up to this point, and I'm looking forward to some questions and interactions, and certainly many more years to come here at UQ. Paul, I can give this back to you.
Thank you so much, Ove. That was really fascinating. And I'm sure that people from not just dentists would have found that really interesting as you explored some of the topics there. And it was, we do have a few questions that have popped up. So if you've got a moment, we might ask a few to you, but I'll also just give the people who are online an opportunity now to just a reminder, if you would like to ask a question, you can use the Q&A button, which you'll find at the bottom of your screen. But to start us off, you actually mentioned right towards the end there about the importance of overall health. What is the specific connection between a root canal or a dead tooth and overall health?
Yeah, that's the multi-million-dollar question. I'm glad that you asked that. Every patient that has a root canal treated tooth will have at least at some point in time have had this question in their heads. What is the real question is a bit more complicated to answer than we can do this in 5 minutes. The simplistic way is to see the root canal treated tooth has empty space in it, right? And technically, theoretically, there could be bacteria in these empty spaces. And the thought process for many people is, okay, this is a big problem because the organism cannot deal with these bacteria. So that is debunked. I think that's more important to look at it from that way. What is not the connection between a root canal treated tooth and overall health? Now, when we establish this, we have to look at it a bit differently in terms of endodontic medicine. This is the buzzword that I think we should probably introduce as well. There are parallel developments and parallel structures in terms of what the body can do. So if somebody has somewhat of a change in the immune system, say a diabetic patient, that type of patient will be less able to defend him or herself against an endodontic infection. So we have to look at it differently. We have to look what is the overall health going to do in terms of a root canal treatment, not what the root canal treated tooth is going to do against the overall health of the patient. So there is a connection, but it's not a cause and effect connection as many people would like it in this video would like it to be. There's an association that has to do with generic and general immune responses that the person has.
Okay, great. Thank you for that. We've got another one saying here, with respect to tissue retention and what's happening moving forward in that space specifically? Is there something you're involved in there, or is it something UQ is involved in?
Yeah, absolutely. So there's two elements to that. So when you think of tissue, the tissue could be both hard tissue, dentin. So hard tissue preservation in terms of dentin preservation is certainly something we are involved in. That means for the practice of root canal treatment, do more with less, achieve the same kind of treatment quality, disinfection, with less destruction. We are making the access smaller. And one of the technological words that people are using is minimally invasive treatment. I'm not quite keen on using this. That is so corny. But what we are trying to do is we pay respect to the tissue and remove only that is absolutely necessary. That's not what people do normally because they need to facilitate access to the root canal system. And the other tissue is the pulp. Vital pulp therapy is something that UQ has crystallized itself as a center worldwide with my colleague George Bogan and myself looking at this at the moment quite intently. And that's a very significant stream. If you avoid the root canal treatment altogether by maintaining pulp vitality, that is probably the tissue retention to the maximum. And if you will, also minimal invasive treatment to the maximum.
Great. From a global perspective, you've shown early on in your presentation that you've obviously spent considerable time not only in Europe but also in the USA and also over in Jamaica, where you mentioned you're volunteering. So you've got a great cross section of what's happening globally. How does it compare to what's happening? How does Australia compare to what's happening in some of those other countries?
Yeah, that's very, very interesting for me. I have only been here for about 4 months now. And in this stint where I had to involve myself more specifically in the healthcare system, what is clear to me is that remuneration, the way the healthcare system is set up, incentivize treatment providers. So that's very problematic because not necessarily will be the best treatment rendered, but the treatment that is probably the most lucrative and the easiest to generate a revenue stream from. That is not necessarily telling us that these people are bad people, but they're being incentivized, right? In Jamaica, there's no insurance. So everything is done by last resort extraction, right? So people are used to that. That's fine. For a 16-year-old girl to have no anterior teeth, that's normal. That is not what is normal in the US and certainly not in Australia. Switzerland is a fairly singular data point. No dental insurance again. People pay out of the pocket. And there's no, for adults, there's no state-funded dental care. For kids that are school age, yes, there is. And yet the dentists have created a system for themselves where they warranty treatments. And the government has accepted that and has permitted the dentists to charge certain fees that allow them to spend as much time as scientifically proven for a particular treatment. That was, I think when I saw that, that was revolutionary. So a restoration in Switzerland has a life expectancy of 8 years. And if it needs to be replaced before, the dentist pays pro rata. So if it's after 4 years, the dentist pays half of it, the patient pays half of it. That is, have never seen any place else. In the US, of course, as you all know, millions of people have no insurance. There's very little dental insurance for the majority of people. I'd say maybe half of the patients would have dental insurance. So yet again, you have a segment of the population that is insured by Medicare. By the way, I have a dog here, so that if the dog starts to bark, that has nothing to do with root canal treatment. I think we're getting something delivered. So maybe I have to go and step to the door really quickly because I'm working from home. If you allow me to do that, because these people are they're waiting here. So give me 1 second. This is life as it could be. Give me a second.
Thank you, Ove.
Of course.
I'll let you do that. For those of you who are still online, we will wrap up briefly. I'll let Ove come back because we have 1 or 2 last questions, and I'll put those to him prior to us closing off. But just a reminder for those of you who are online, or you may have colleagues who aren't online today.
So
no, that's okay. I was just explaining that this is being recorded, and so we'll share this for those who couldn't make it online, because we appreciate a lot of people are actually at work as we speak, and a lot of people watch these later on. So if you do have questions from colleagues or anything like that say, oh, were you able to see it, just let them know that will come, the recording will come out early next week. Yeah. But sorry, Ove, where were you?
No, I'm sorry. But that's the fun thing if we're doing this live. I talked about the US a little bit, and for me, the experience is new here in Australia that the government-controlled healthcare system is actually very strong and provides an excellent service for a very significant proportion of the population. And so in that sense, it remains to be seen how the individual systems can take up let's say the most modern and most advanced concepts. And then the question of incentives to do certain things is less money, but maybe going back and say, this is the right thing to do, and therefore we do it.
Excellent. All right. Well, we're getting to the point where it's probably time to wrap up, because I'm mindful that we've obviously had a great session. There's just one last question. Actually, a couple of people have worded it in different ways, but people were very curious about the paper you referenced towards the end about abandoning ship, and they were just curious if you could clarify or reconfirm the title and the author that they can look for.
Yes. So John Ioannidis, he's a statistician at Stanford, and he has a whole bunch of, probably one of the most prominent biostatisticians in the US. He criticizes, and that's his forte really, he looks at specific things and he's critical about a number of bits and pieces. I don't know what is the good custom here, Paul, so if anybody emails me, I'm happy to send this particular paper through. You'll find him, of course, on PubMed. The spelling is the Greek name Ioannidis with I-O and A. And he has really a series of interesting papers. This particular one that I talked about was very critical about biomarkers and certain treatments that are driven by, let's say, purely molecular outcomes. And so he says statistically, some of these things are not helpful. And but the point is, if we perpetuate the same things based on erroneous strategy, an erroneous starting point, then who decides when we should change it? You know, that's the abandoned ship or reversal of acknowledged practices take. So I think it's a worthwhile read, but he has a couple of others that are equally worthwhile. Very controversial, but very well written.
That's fantastic. Thank you. Well, what we'll do, Ove, is I'll put that in the email that we send out next week. I'll include the name there. So for those of you who didn't actually get a chance to write it down, or you had any clarification on exactly where to find it, I'll put the details in there so you'll be able to track that down that way. But at this point, I think we've probably got to the point where we're going to have to wrap things up. Ove, I want to thank you once again for taking the time to explore this subject with us. I think it was really fascinating, and we're very appreciative of your time. So thank you very much.
Anytime. Thank you.
And to those of you who have joined us live and those of you watching the recording, thank you very much. If you'd like to see more of these recordings, we've got the HaBS Alumni Webinar Series running weekly. You'll be able to find the link to that once again in the email that comes through. Thank you once again for your time, Ove, and have a great day.
Thank you, everybody. Much appreciated. Bye-bye.